My name is Kevin Campbell at the University of Iowa. With Kathy, we run the Wellstone Muscular Dystrophy Center, which actually focuses on the dystroglycanopathies. Kathy's involved in the clinical aspects. I'm involved in more of the basic research, and also Steve Moore is part of our team, who's does a lot of diagnostic work and actually now getting involved in testing the outcome of therapies, which is kind of exciting. So we're here to answer your questions. We'll pass the mic around and let everybody introduce themselves and then open it up to questions.
Right, my name is Ann Bang. I work at the Sanford Burnham Prebys Medical Discovery Institute in La Jolla, California. This institute has a state-of-the-art drug discovery center called the Prebys Center, and my lab is within the Prebys Center, and we have a major focus on rare diseases, and in particular using patient cells and stem cells we make from patient cells to develop models to screen for and test for drugs. And we've been working on the dystroglycanopathies for the last 5 years or so.
Hi, I'm Kristin Zhukovsky. I did my graduate work in Karsten Bonneman's lab at NIH. And now I work at NIH in the Office of Training and Education, and I work part-time for CareCMD, helping to write the reports for these conferences.
Hi, I'm Megan Leach. I'm a nurse practitioner. I work at Children's National and at NIH, and soon we'll be moving to Oregon to be a neuromuscular nurse practitioner there as well.
Hello everyone, my name is Anna Sarkozy. I'm a clinical geneticist working at the Dubowitz Neuromuscular Center in London with Professor Montoni. I'm mainly a clinician and seeing children in clinic with neuromuscular condition. And I also have a major interest in research on new genes and understanding better the phenotypes and the spectrum of the different condition. And in particular, I have a major interest on dystroglycanopathies.
I feel weird. I have no education. I'm Debbie, and my daughter is Abby, and she has dystroglycanopathy large.
And I'm Debbie's mother, and Abby's my granddaughter.
Hi, I'm Dee Ann Kobayashi. I'm a neuroscientist, and I'm on the board in the scientific advisory board for CareCMD. I'm a drug developer. I work in companies that create new companies in the rare disease space, and I'm trying to be here to help.
Hi, Joe Pinkelman. This is my daughter, Maya, and Maya has a POMT1 dystroglycanopathy.
I'm Ann Troughton. My son Jack had he passed away 4 years ago, but I'm still very interested in. He had an undiagnosed dystroglycanopathy. In fact, his neurologist is Ann Connolly, and I believe you did some testing that ruled out what he did not have. So.
I am Edmar. I am from São Paulo, Brazil, University of São Paulo. I am a physician and a neurologist, and my main interest in muscle disease in children and adults.
And I'm Kathy Mathews at University of Iowa, the clinical arm of the Wellstone Center. I'm a pediatric neurologist. I see children with a range of neuromuscular diseases.
So maybe I could ask a question. As a clinician, where sort of are we in the world of research and possible treatments in the ADGs?
So I think you asked two questions there. One is what is current management, and secondly, are there treatment options in development? Would that be accurate?
Yes.
I'm assuming I'm talking loudly enough that this is heard. So perhaps we can address what we feel is current management and then let Ann and Kevin.
Would that be helpful?
Yeah, definitely.
So one of the things that I'll just go first, and you would feel free to jump in, Anna.
All in layman's terms, though, please.
So, well, one of the things I was going to address is the steroid question, and I mean that remains very much a question on the table. I have put a number of patients on steroids, but I do it very cautiously. I think people with mildly progressive disease, the side effects of steroids outweigh the benefits. And my personal style is that I never put people on chronic daily steroids. I do an alternative dosing regimen because, again, minimizing the side effects. I've had patients with various forms of dystroglycanopathies who felt that it was very helpful, and I've had other patients who felt that it was not helpful. I can tell you that I have for many years considered trying, and Volker Straub had looked at trying to do a clinical trial in steroids. With the data that we have, I think that a clinical trial in adults with LGMD2I is probably not very practical because it's very slowly progressive, and I, again, am worried about the risk-benefit ratio. I am very interested, as these guys are going to address, as many drug companies are becoming more interested in the dystroglycanopathies and are interested in starting to talk about treatment trials, I think, and we know that there are children around the world, some of whom are on steroids, some of whom aren't. I think actually the time is now to try to do a trial in children of steroids, because we need to know what to tell the drug companies the sort of baseline therapy should be, or if there is benefit or no benefit, so that we're going to be working with very small numbers. If we have very different baseline care in terms of something that is disease modifying, I think we're going to have an even more difficult time interpreting any new therapeutic results. So I've started trying to draft an outline of a steroid trial for children, because I think we need to do that. This is the time because of new therapies coming on board. Other things, I think cardiac management, one thing that we have done, and we have a paper that is under revision now, looking at cardiomyopathy across dystroglycanopathies. In our series, we have very few patients who have developed cardiomyopathy by echocardiogram in the non-FKRP dystroglycanopathies, but we have very good data on the FKRP dystroglycanopathies across different phenotypes. So I think, and the bottom line is cardiac monitoring is critical. Respiratory monitoring, whether it's with sleep studies or overnight oximetry studies, forced vital capacities in clinic if you can do it, supine and sitting, forced vital capacities if you can do it, critical. Obviously the physical therapy management, the other things that are a routine part are all part of neuromuscular care, are all critical. Anna?
Yeah, so I completely agree with what you said, and this is also the point that I would have highlighted. So with steroids, just to follow what you said, we have some experience, but it's relatively limited, and it's literally you try and you discuss with families what could be the benefit and side effects, and very often you choose to go for the alternative. In particular, those who have symptoms in adulthood, you might have some benefits with some drugs, but that's very specific for that subtype, the GMPPB gene, the new type of dystroglycanopathy. But I agree that management is the most important thing, and I think it's important that the doctors that you see are aware of what are the implications and what are the possible problems that could happen also later in life. So it's very important that the management is done and following the standards of care that we have at the moment. I think it's also for the undiagnosed patient, this is very important that when you don't know the gene subtype, that the affected individuals are still following all the same monitoring, because you have to think about all the possible problems that could be happening to heart, respiratory, and so on.
We have so many genes causing alpha-dystroglycan.
Yes.
How to choose patients for steroids in a clinical base, or there is some specific genes that the response is very, or you don't have this sense of?
So I can answer first. I mean, in London, in the cohort of the patients that are coming to our clinics, we have mainly patients who have FKRP mutations, but we also trial steroids in children who have other type of dystroglycanopathy like POMT1, but it was more like a slightly milder presentation. So it was a POMT1 mutation that was also more like a limb girdle presentation, and it was literally it according to what is the problem of the child and the patient and the discussion. I don't think that it would exclude it with other mutations, but it depending on what are the benefits that you would like to achieve. So in this case, this specific child, the steroids were tried in his when he was 7 or 8 years old, was still functioning really well, and the aim was to try to prolong and keep the strength for a long time, and it was actually giving very good benefits, and he's 18 now and he's still walking. POMT1 mutation.
You would suggest steroids before they're not? My daughter's still mobile and is still making that really tiny growth, but sorry. So what I had heard before was once they kind of plateau and they're not making any more progress, so now it's more a standard to try steroids while they're still moving?
I would say in the U.S. I would not say that that's standard.
Okay.
No, it's not standard. It's not standard. It's something that you can discuss. It's not standard. And as I said, it's a fairly low number of families where we had this discussion. But we did try in a few situations where we felt that it was potentially the benefits we could have expect some benefits. So it was a discussion. It's very much depend on how the condition is progressing. And so it would be quite specific to the situation. If you see that there is a plateau and maybe the condition is starting there's a little bit of deterioration, you can then think of maybe giving it a try and see if that can help to maintain abilities. Okay. But if there are I wouldn't suggest steroids if the condition is relatively stable, if the mobility is good, if you know what I mean. Yeah?
I want her to be as mobile as possible, but
right, and steroids do have significant side effects. So it's now been a couple years ago, but I have patients, if I just take outcome measures, like all the spots, all the little dots for every outcome measure at every age, and then I make the ones that are on steroids a different color, they do not look better than the rest of the little dots. And I have patients, particularly a few who were originally misdiagnosed. I mean, they were old. They were so before the ages of our current genetic testing. Who I question whether they're doing worse than their genotype would predict, and whether the steroids have been harmful in some of those. So I think that and at the same time, as I said earlier, there are definitely patients where they have clearly gotten worse over a fairly rapid period of time. We give them a burst and then we put them on an alternative regimen and they are doing better. But the indications are not yet clear, and I would not say that everybody with a dystroglycanopathy should be put on steroids.
You both mentioned alternative regimens. What do you mean by that?
So we mean either every other day or high-dose weekend or 10 days on, 10 days off, depending on what your center is, what the phase of the moon is. There's no good, but something other than daily steroids. So daily steroids is the one that you have the most side effects with. So anything other than daily steroids, you will have fewer side effects. And I think all of us are very concerned about daily steroids in this group of patients.
If I can just add that we have a lot of experience with steroids in another group of muscle conditions that are relatively similar in some aspects, called Duchenne muscular dystrophy. Okay. And in that case, in that condition, we know that steroids can give benefits, and the idea is that the benefits outweigh side effects, and that's why this is something that is recommended at the point where the condition starts to plateau, and you would expect that after there might be a change in abilities. So you start the treatment to sort of try to slow down, okay? But we do know that according to the gene change, what type of change you have, and according to the abilities, which are very different, even with the same gene change, the same gene, you can have completely different difficulties. So even with the same genes, when we are talking about here different genes, different mutation. So even with the same gene, you can have different benefits, different side effects. It's really much, person by person that you choose and decide and discuss. So it would be different. Definitely, it's not a, we recommend steroids in general. That would be extremely not right. And if there is, you really start this discussion when you think that you might need to treat something that is deteriorating and is getting a bit worse. So.
And then just as you guys were all mentioning, another thing is reassessment, and so just making sure that if somebody is starting on steroids, that then they're reassessed, because if you're not seeing any benefit, then there's no reason to stay on it. And so coming off of it if you're not seeing any of that benefit.
I have one question for you guys concerning the steroids. There's some new steroids that are being developed. Any experience with these new steroids with dystroglycanopathy patients?
So the one that is under trial right now for Duchenne is not available to us, so we can't. The other one is deflazacort, which is available, and yes, I have patients on deflazacort rather than prednisone.
Yeah, so
Deflazacort's easier to get.
Yes, in the UK, deflazacort is quite easy, and they have a big number of children with other muscle condition with deflazacort, and also with dystroglycanopathy. So probably because some side effects are a little bit less common in deflazacort, it somehow is chosen as maybe a little bit more frequently, but we don't know yet if it's better or not compared to other drugs.
And in the U.S., it is approved.
Exactly.
It's approved. What am I talking about? So now we cannot get it for off-label use. We cannot get it for off-label use now. It's only approved for Duchenne muscular dystrophy in the U.S. So it requires a letter and a bag and a lot of paperwork. And a lot of money. Prednisone is maybe $10, maybe $100 a year. To the insurance company, deflazacort is at least $50,000, depending on the weight of the child.
There was something else I wanted to mention is that, and again, talking with experience from more common muscle conditions, that we see that steroids give benefits, but it's the general standards of care that have massively improved over the last 10, 15 years. So we can't forget that all the children who are taking also steroids, also benefiting from the massive advance of care in general that were not available maybe 20 years ago. So respiratory support, cardiac care, orthosis, rehabilitation, and or general, holistically, a different approach to these conditions. And I think that is probably as important or even more important in general to improve the quality of life of patients.
Do Kevin and Ann want to comment on that?
So in terms of your daughter, you said she has a large mutation? Yes, so large it's interesting. She has the CNS abnormalities, but really very mild muscle phenotype. And large is the only form, large 1 is the only form of large expressed in the brain. Where in other tissues there is some large 2. So it could be that she has compensation in the heart and skeletal muscle. We don't know that, but that's one possibility why her muscle phenotype is so mild and the CNS phenotype more severe.
Is it typical of large patients?
There's not many large patients. Yeah. There's probably.
You're special.
Yeah,
we love being special.
Yeah, there's probably only maybe 10 that have been reported. Do you have? You have 2? Yeah. So there's not many large patients, and Yeah, so,
there was 3.
Then there were 2.
yeah. Yeah, so it could give us some insights on, on treating the muscle side of things. Somehow your daughter's compensating or has a modifier gene that gives the muscle phenotype. Like the study was recently done on the mild Duchenne dog in Brazil by Mayanazats and Lou Kunkel, where they found a modifier gene, by looking at a mild case of Duchenne muscular dystrophy in the canine. It could be an insight pathway towards a therapy. In terms of the CNS phenotype, for years a lot of people.
What does that mean?
Sorry, central nervous system, brain,
thank
brain.
you. Sorry.
Yeah. So the investigators and clinicians and scientists would say you could never repair the brain, the phenotype. But there's more and more studies coming out that the brain is more plastic, and there was one recently done in a mouse model where the mouse had an abnormality in learning and memory, and then they turned the gene on at 6 months of age and actually could see improvement. Steve Moore, our colleague at Iowa, he does neuropathology, and he would say, the brain is, it doesn't look right. But it seems like even if it doesn't look like it's wired correctly, it could still function. And so that's a possibility that some of the therapies might help, in terms of your daughter. It's a long way away, but I mean, for a while people thought it would never be possible to repair abnormalities. And with the screens like that Ann's doing now, if you're looking at neurons in a dish, she could be developing compounds that would actually try to repair the defects that are occurring in dystroglycanopathy brains. So.
Do that real fast.
Yeah.
There's always possibility for breakthroughs.
Yeah. So what was the
Other therapeutic.
other therapeutic? Yeah.
Dystroglycanopathy.
Yeah. So I'll let Ann cover. So there's a defect in the glycosylation of dystroglycan, putting these sugars on, and there are several different therapeutic approaches. And yesterday I mentioned gene therapy, where you would use the defective, put in a correct gene, and that's gene therapy for muscle disease is progressing pretty quickly with Duchenne muscular dystrophy. For the dystroglycanopathies, it's a little bit more complicated because these are enzymes and the dosing would have to be correct. But that's something that's on the table, and I think will happen. A lot of the initial work is going to be worked out in Duchenne muscular dystrophy. But once if that becomes routine, then I think there'll be attempts to do gene therapy for the dystroglycanopathies.
Just published his appeal.
Yeah. And one advantage the dystroglycanopathies have, all the genes are small enough to go into the vector called the adeno-associated virus vector. So the problem for Duchenne has been always that the gene is so large that they couldn't fit the entire gene into that adeno-associated virus vector. So I think gene therapy is something that's going to be coming along. The second type of therapy would be to restore the link, and this is not the pharmacological approach, but more of a protein approach to try to, something that's been done recently for laminin to the cell membrane in the absence. And so I think there's some protein possible therapies. A company named Genzyme is working on one of those right now for the dystroglycanopathies. It's early stage, just in mouse models, but that's another possible approach, is a protein therapy. And Genzyme has had lots of experience in protein therapies for Pompe and several lysosome storage diseases. So that's a company, and that's their approach. And then I'll let Ann talk about her approach in terms of looking at small molecules.
Yeah, so the other approach is small molecules. And like I said, the focus of my lab is actually using patient cells to model disease and then look for drugs to improve the phenotypes. And all patients are different. Like you were saying, there are patients that have the same gene that's mutant, and they have different phenotypes, and everyone has to be treated as individuals. So the hope is that this type of approach is going to help. One thing that happens in clinical trials is that all peoples with one disease will be sort of grouped together, and then only a few of them will respond at all. and then the trial will be a failure, and the FDA won't approve the drug, right? Because they didn't meet a certain metric. And so the hope is with these types of approaches where we have more patient-specific models for testing the drugs, that will lead to quicker identification and approval of drugs. And I think this idea that that Kevin mentioned, that for instance in the case of large, there's a large tube possibly that's providing compensation in the muscle and in the heart, but not in the CNS. Those types of observations lead to new drug targets. And once you have a target, a specific gene that you say, well, if I modify this, then the drug seekers can focus in on that target. And I think so there's a lot of progress being made in that regard. But drug discovery, it is a long process, sometimes there are unexpected advances, but it takes about 10 years or so from the point where you identify a good target to where you have a drug to take to the clinic, so you have to be patient. But definitely, there's a lot of really interesting stuff going on with cell therapies and with gene therapies. I mean, cell therapy is another possible approach. And I previously worked at a company where we developed a cell therapy for type 1 diabetes using stem cells. And that is now in a phase 1 clinical trial. And it took about 10, 12 years to get to that point. So I would be cautious but hopeful, right?
I can make one more comment, and that is that in the last 6 months, there have been 3 drugs, if you count deflazacort, approved for rare neuromuscular diseases. Now, they're more common than our diseases. They're Duchenne and spinal muscular atrophy, but they are both genetic modifying therapies. And I think Joe sort of defended the MDA, and I would say that one of the things that we all benefit, so in the area of rare neuromuscular disease, the fact that there have been therapies that have been past FDA scrutiny and have gone forward is of benefit to all of us. So the advances in one disease are actually a positive for all of us, and so if the more common rare diseases make progress, that tells investors these rare diseases can be mutable, can be treated, and it's worth, and can get through FDA scrutiny, and it's worth your energy and money to put some effort into it. So one of the advantages of the MDA is it does have that whole umbrella approach, and the community is very large. The community is wide. The neuromuscular community is very wide, and we do all benefit from the successes in our neighbor diseases.
Are there things that we as parents can do to help our kid more now? I mean, these drug trials and things are way past where I'm looking at things that I should be doing here and now, whether it's homeopathic things or things that you would see that have worked with your patients to keep her on the right track.
No. I guess so I think first of all having a very regular and holistic care, so which includes also different aspects of these conditions. So not forgetting important organs in the system like your heart, your brain, your breathing, and not just the muscles and the brain. And so it's important that your doctor is aware, and often families can actually also prompt clinicians if they're not very acknowledged. So, these are the problems that might happen with my child or with my family member, or with myself if you're the affected person. And in terms of I think having a healthy lifestyle, being active. So if your daughter's muscles are working well, and that's good. It's good to continue to use those muscles and being healthy, good diet, and balance. I think we don't have evidence yet clearly proven of specific supplements or things like that, but I think common sense.
Does she have a high CK?
Is that the muscle enzyme
That's
thing?
yes.
2200, I think, was what it was when.
Yeah. So I would say to avoid eccentric contractions.
Yes. So
Avoid these guys, these guys are explaining.
That's not necessarily easy to do in real life to define. So there's if you run a mouse on a downhill treadmill, the mouse with a dystroglycanopathy, the mouse will have injury to muscle. So there is the theoretical risk that if you run a human on a downhill treadmill, that they will also have accelerated injury to muscle. There are also studies that have come out of some exercise physiology sorts of labs that say, so it's a balance between muscle building, because we all, if we build our muscles, we get stronger. So it's that balance between the injury to muscle and muscle building. And I think in a human setting, that if I put somebody to bed for 2 weeks, they will come out infinitely weaker. So that's where we're saying, we encourage you not to have a physical therapist or a coach put her on a weight training regimen. But
Trampolines? Trampolines? At least I've heard trampolines are not.
So, but maintaining an active lifestyle, doing things she wants to do, and doing normal kid things, and recognizing that if she's in profound pain or if she has Coca-Cola colored urine, those are signs she overdid it, and that activity needs to be modified.
She won't tell us when she is too tired. She just goes and
Sits down.
She just goes. She doesn't stop.
So if the next day she is crying and in pain, then you know that yesterday she did too much. Or if she ever has Coca-Cola or tea-colored urine, that would be a sign that she did too much the day before. But it is difficult. You should not restrict. I would say you should not restrict her normal preferences.
I couldn't. Unless I strapped her in her stroller.
Right.
She is 12. She's 12. She's about 54 inches, so she's real short for her age, but she goes.
And also they seem to be very sensitive for virus infection, and I think you have to take care of vaccination.
So some people with dystroglycanopathies in the setting, particularly young children, in the setting of a viral illness, will have a dramatic decline in function. And that dramatic decline in function recovers over time, but that recovery might be sped up by a steroid burst. Did she ever have an episode where she had the flu and she lost the ability to walk or move more than
The last time we saw Dr. Bonner, which actually was a few years ago, he was telling us to watch out for fevers, because that he felt was something that could start the progression of the disease, and I'm really careful.
Yeah, and most of the time that illness-associated worsening occurs in the younger children, and she's past the sort of period that we most commonly see then. Good point.
I was going to address something too when you mentioned the homeopathic. And so we're breaking the rules of the prednisone, because we're tapering it back. So I mentioned we're like 35 milligrams every other day, and now we're down to 25.
So you're doing every other day. You're doing an alternative.
Yeah, and then we've scaled back to 25 milligrams. But as one of the drawbacks is her bone density, and so it was in December. Her aide had her sitting in go to the bathroom was at a toilet that was, even for us, regularly developed, it would just be almost impossible. It's a feeling like you're below level squatting, and they weren't seemingly aware of her circumstances. I mean, if you were regularly developed, you would have really had to shift, push, move up. Okay, so she's not going to do that. So in trying to do that, she developed. She started, started just crying, was pointing to her leg, and crying all day long. And the aides just thought, she's just pebble in the shoe or something, some kind of discomfort. at the end of the day, they couldn't she couldn't get out of the car. And so Anna called and said, just take her straight to the ER. And, so we take her out on a gurney, do an x-ray, and she has to have stress fracture on her left, right up on the top of her fibula. That's the bone in the front, yeah. And so, but it was just very minor, and that's why she wasn't able to bear weight. And so she recovered from that because we thought like, oh my gosh, now she's not going to be ambulatory in any way, shape, or form. But, so we did the Hoyer lift initially, and boy, what a crazy trying to navigate that, to get to the toilet. So my point was then, so her internist then was doing this infusion of like these 50,000 gram like bombs of vitamin D, and that really wasn't too effective. But through this whole time that we've been doing the prednisone, we always been following like a daily of like 1,000 milligrams of calcium. So it's a two-edged. So I mean, we know that her bone density is like definitely like she has really like brittle chicken bones, but at the same time, genuinely, like in her case, the strength, she really was truly weak, like just resting her head, like couldn't lift her head up off the table. And so it was that was when we started the prednisone. So she's maybe that strange like bird in flight that just is able to like, it really is, there's a efficacy to it. But definitely the downside, I mean, you can see her now. I mean, there's, the weight gain, probably just mitigating her height development, some issues of acne, but not, hasn't been terrible. But definitely the bone density, and that, certainly, her orthopedic said, well, yeah, I mean, you're playing with, she's now on a steady diet of steroids, and so you're really like manipulating the whole body, metabolism. So, so that was the downside of it. So trying to, we reinstituted the calcium, but it's like, how effective is that? It's not we're going to regain bone density. I mean, we're trying to just keep it from getting worse and worse, essentially.
Bone density is a risk for anybody who's in a wheelchair with or without steroids. So that's another reason for your daughter's daughter, right? Abby's level is in a good place with regard to that. Walking is going to help maintain the spine straightness and is going to help maintain bone strength. Yeah, I mean, walking is good for the human body.
So do you suggest anybody? Jo was saying calcium. I mean, she takes multiple vitamins every day, but because her
So you're going to,
the best.
yeah. So your style, I'll answer and then let Anna. I mean, we all have slightly different styles. I don't routinely do bone density analysis on kids who are walking and have a normal diet and are not on steroids. So I wouldn't, with your daughter, unless there was a history of unusual fractures, I would not probably pursue that, but people will have different styles.
We routinely do the same, so we don't do bone investigations in children with neuromuscular condition, apart if they're on steroids. That's for sure in that case. But on the other hand, we emphasize that bone density can be reduced if you are not as weight bearing, so standing, walking, putting weight on your bones makes them stronger. So walking is the best thing. But if your mobility is not good or you're walking less, definitely you need to be even more cautious. So having vitamin supplement, vitamin D cannot be, you don't have enough vitamin D from food. So the best is sunshine. And in the UK, the sunshine is really little. So we literally
Philadelphia area, there's sunshine.
Good. But we recommend that children who have any type of neuromuscular condition should take a lot of vitamin D, like 1,000 units daily.
So, and we usually monitor the vitamin
Yes,
D level. So, I
exactly.
mean, it's something you can draw. So if her vitamin D level is totally normal, then she doesn't need extra supplements. And it's cheap and easy.
Is that something I would ask her pediatrician to do, or
You can ask her
muscle doctor?
You can ask her
Anybody,
pediatrician to do it, but usually with the pediatricians, they recommend a sort of a low. They have a lower threshold for normal. The typical vitamin D range is usually between between 30 and 100 is like the normal range for vitamin D in the blood. But for me personally, I prefer it closer to 50. I don't know what you guys think.
I aim for above 30.
So, I mean, that's just,
What do you do?
yeah.
Is it milligrams? Nanograms. How do you-
Nanograms per what, something like that.
We aim for 75. That's what I'm asking. The thing is that you're different. Yes,
We
different.
must be doing
Yes, yes.
Well, no, but I mean, but I
yes.
think our recommendations are sort of based on nothing, and so it could be,
No, I
it could be
I
that,
think it's a different measure in the UK than
it could be, it also could be, that's,
But
but,
75 would be very hard to hit.
Yeah, I
even
mean-
if you went out and you spent all day in the sun and, you know.
Yeah, no, no,
and,
yeah, that's the
and
thing,
Philadelphia,
it's different.
like, we are all deficient in this area, like, even in DC, like, we're all deficient, and so I'm sure that the kids are deficient in Philadelphia. I know the kids are deficient in Philadelphia.
We're not quite in Philly, but close.
But yeah, but still, like, I mean, because this whole region, we're all deficient. Like, people are deficient, and then our neuromuscular kids are all deficient, and
Unless
so
you
we.
draw the vitamin D in August, when they've had 3 months in the sun.
Yes.
And then, but if you draw them in January or February, they're all deficient.
And what the CMD care considerations say is that it should be drawn in late winter, and the care considerations say that there should be a bone density test done at 10, but I don't know what that's.
I don't think there's
I-
any data. These
No,
are
it's-
style.
Yeah, and so for me, I recommend bone density tests in the ambulatory patients, like if they're going for surgery, for like scoliosis surgery or something. I recommend it before then because I want to make sure that the surgeons are going to be able to be okay and not mush something like a bone. But that's not usually an issue in the ambulatory patients. But
And honestly, our surgeons don't have any trouble with working with osteoporotic bones either.
yeah, I just like them to know what they're getting themselves into. But for ambulatory patients, yeah, unless there's a fracture, we don't do bone density.
You mentioned there's also the scoliosis. I mean, something that's also just been not expensive, you know, in terms of an arm and a leg. It's just our local YMCA, and so Maya does swimming like 3 times a week, and just the lifeguard instructor just floats, so it's very non-weight bearing, but she's if you looked underwater, she's kicking her leg, just even using the little noodles. And the YMCA is very inexpensive, $75 a month or something like that.
Ours makes them wear a life vest.
Yeah, she wears a little life belt around her.
Not like a life
And,
vest, she can swim, but she won't
No,
float.
no. There's this. I can give you the information. It's these little belts, and so Maya's probably about 140, and so they small, medium, large. These belts clip on, and so she's able to just stay. Doesn't tip forward, doesn't tip back, floats feet. In about 4 feet of water, and going back to her orthopedic. Pediatric orthopedist, because he goes to the MTU and checks, every year does a follow-up, and is always checking and no scoliosis issue. So he's always encouraged the swimming as well, and just because, she's obviously we're noon, and she's been sitting in this since 7 a.m. And so, you know, that's a long time. So 3 times a week to really do that movement. On YouTube videos, there's a lot of these videos for the Duchenne clientele of like stretching exercises. So she's a little adverse to some of those, but incorporates them. And so, you know, just simple little things like that. So, you know, the scoliosis is also a issue. And, you know, so I think at, you know, approaching 19 and not, you know, being wheelchair bound quite a bit, you know, not that being an issue. So again, something that's not expensive, and in her case, she actually really is, you know, still ambulatory, because Maya was that till about like 8, 9, and then has been wheelchair bound. So, you know, just once or twice a week, being able to do that, I think also is beneficial. Because so many of the families with scoliosis issues, I think, oh my God, all these like fusion surgery stories, it's just like, oh my, I just cringe. And so I think like, wow, that's another bullet dodged, you know, so far, you know, knock on wood, but that hasn't been an issue. So something merited that. So no, that helps. I was able to get Anna before she's off. I was mentioning to Kevin, she's on her way to the stairs. I said, did you have any questions? She said, no, I'm okay. So yeah, that's why I was on the phone initially trying to get in touch with her. It was like before she like went out of range, and then I got a text. So, and I think like primarily her before talking, you know, before coming, I mean, somewhat what we were talking about was more issues of just the care, so to speak, because on the scientific front, I mean, she knows as much as you do, like, you know, so much of it, like, you're, you know, a gain here, not a gain there, what you alluded to, Kathy, too, you know, like, and Kevin, too, you know, within the Duchenne community, and moving forward with that does, excuse me, trickle down, and
I can give you
funding
a
issues.
little bit of an update. When Maya was first diagnosed, I think her grandfather was interested in helping support research, and gave us some funding to make a mouse that would mimic Maya, the two mutations that Maya has. And we actually made the two mutations and crossed them, so we had to get the exact genotype that Maya has, and the mouse has no phenotype. And this is one of the problems we have, is that, you know, the Maya is mild enough that in the mouse form, which mice only live, you know, a short time, a year or so, that no phenotype develops. And so we still have those mice, if we have any new ideas, but it wasn't useful in terms of having a mouse model that would exactly mimic Maya's phenotype. Now, since then, we've made a floxed POMT1 mouse, which is a way of putting something around the gene, and then we can remove the gene just in muscle. And that's showing a phenotype. And I have a postdoc that's studying that. So it's not the exact, you know, genetic, you know, mutation that Maya has, but it mimics the loss of POMT1. And that gives us a chance now of having that allele with one of the other missense alleles. So it's interesting. And Maya has one missense mutation, which is something that potentially could be druggable if we understood what, you know, a little bit better the function of POMT1. It's a very complicated enzyme. It has lots of transmembrane domains, and it's really not fully understood. But you know, eventually, if we could understand that enzyme function, then you could think about developing drugs. And screen is one way of screening. Another way of screening is when you have the enzyme to try to design drugs that would, you know, modify that enzyme.
And there are assays for POMT1 activity.
Yes.
So that's a possibility.
Yeah.
Right?
Yeah.
And I've actually made stem cells from Maya. So we have induced pluripotent stem cells from Maya, and so we can make neurons from those cells that have the same mutations, and they're human. Right? And so that has possibilities in the future for modeling the disease as well.
Yeah.
I was just going to ask for a little update about, is there new evidence about the, overexpression of large, or with the gene therapy, do you think that it's really going to be, yes, we're making progress in Duchenne, but when you're talking about alpha-dystroglycanopathies, if you're then having to subdivide, are we going to have to do gene therapy for each different enzyme, or do you think there's a possibility that there is hope
So
for?
I think actually the gene therapy for each enzyme, depending on the FDA rules, that might be different, but not, if really gene therapy works with micro or mini dystrophin, it should be possible with these, dystroglycanopathy genes to follow up, rather quickly. Right, but I don't know how getting it past the FDA. That's another question. But if in the laboratory setting, it would be easy. In terms of the large question, so I think all the work that's been done on large, it's been probably overexpressed. So I think a small increase in large, which you might get with a small molecule, it could be beneficial. The problem is that large activity is actually tuned during muscle development and also muscle regeneration. So when a muscle cell is a very large cell that's been fused from thousands of cells, when it dies, you have satellite cells that are in the muscle fiber that start to divide and form new myoblasts, and then they start to line up and they migrate and they form a whole new myotube. And so we're really good at doing this regeneration. The satellite cell is probably the first stem cell. You talk about stem cells these days. Satellite cells were discovered 30 years ago, and we knew the activity of these cells probably 25 years ago. So it's really an exciting cell. But those cells have to migrate to make this new myotube. If they're expressing too much large, they get stuck and they don't migrate. And so when you take a mouse that makes too much large and cross it with an MDX mouse, actually the phenotype gets worse because it can't regenerate. And so the regeneration is really important. And the drug, the modifier gene that was discovered with the dog studies that Mayanna Zatz did is really a gene for regeneration. And so I think that's one aspect of muscular dystrophy research that I'm not sure if anyone's really working on. But I think all of these diseases, if you could improve regeneration tenfold, you would make a dramatic effect on all the diseases. This seems like from the studies that are out there that maybe companies are working on that, but that would be something really helpful.
Has the Duchenne gene been tested in the?
No. So that hasn't. It's JAGID1 mutation. That doesn't directly give you a drug to test. I think Beth McNally is looking for, because she works on a lot of modifier genes. So I don't think anyone's found a patient yet with a JAGID1 mutation.